Recording has started.
Well, welcome everyone to our innovative discovery series. Today we have a real treat. 4 talks, 5 speakers will present their COVID-19 related community engagement research projects. But first, let me briefly mention some housekeeping issues. So as you know, we are providing CME credits for our tech talks and our ID series presentations. We will distribute the information via email to those that registered for today's event. If you did not register prior to today's talk, you can still obtain CME code information from Lisa Maturo at Christiana, and I will provide her address in the chat. Our next ID series will be December 18, so it's next week. Our speakers will be Dr. Susan McCann from Nemours and Dr. Stéphane Meist from MUSC, and they will talk about the N3C Data Enclave, which is a new COVID-19 registry sponsored by NIH. And we will have, after the holidays, January 7th, a tech talk. So let's start. It is now my great pleasure to introduce Dr. Lee Pachter, who is a co-lead of the Community Engagement Outreach Core and Christiana representative on the CTR Professional Development Core. At the Value Institute, he is a senior physician scientist and director of mentorship and professional development. So thank you, Lee, and the microphone is yours.
Great. Thanks, Claudine. Welcome, everybody. So welcome to the ACCEL Community Research Exchange, Part 1. Today, we'll be hearing from 4 groups of researchers who were awarded ACCEL COVID-19 Quick Step Rapid Science Grants, that's a mouthful, which supported short-term 3-month projects pertaining to the pandemic. Today, we're highlighting 4 of the projects that fell within the health services and community engaged end of the translational research spectrum. So each presenter will have 10 to 12 minutes to present their projects. In order to make sure we have time for all of the 4 presentations, we're going to save the questions to the end of the hour. So if you do have a question for any of the presenters, please type them into the chat bar. And if we have time at the end, we'll select some questions. We may not, because it's going to be a full hour. So by the way, part 2 of the Community Research Exchange will be a half-day virtual conference on February 18th. I believe that the save the date announcements were sent today, so check your email. And the info is also on the ACCEL website, so please mark your calendar so you can attend this part 2 event. Great, so let's get into the presentations. Our first presentation is titled Clinical Nurse Perspectives on Implicit Rationing of Nursing Standards of Care During COVID-19, a Qualitative Study. And this will be presented by Dr. Monica Rochman, who is Program Director for Nursing Research and Evidence-Based Practice at Christiana Care. Monica. You're muted.
Thank you so much for the introduction, Lee, and thank you so much for the invitation to be here today. Of course, I try to get this to go flawlessly, but there's always something in 2020. So now I'm going to attempt to share my screen. Okay, let me know if you're not seeing it. You seeing it okay? Great. Okay, well, good afternoon. Thank you for the introduction. Again, my name is Monica Rochman, and today I'll be presenting preliminary findings of a study entitled Nurse Perspectives of Implicit Rationing of COVID-19 Patients, a Qualitative Study. I was led by myself and co-investigators, Dr. Austin Mount Campbell, FDI, and Kathy Fernald-Shaw, Chief Nursing Officer. This study was funded the study was funded by Delaware CTR Rapid Grant, as already discussed, and all the investigators have no conflicts of interest. Implicit rationing and missed care are both universal phenomena experienced by healthcare on a global level. A systematic review revealed that recent estimates of the prevalence where 1 or more tasks are left undone are between 55% and 98% internationally. Implicitly rationed care is defined as the failure to carry out necessary nursing tasks. It is characterized by scarcity of resources, time, or an abnormal work environment with unfamiliar patient care needs. Similarly, missed care is defined as any aspect of required patient care that is omitted either in part or hold or delay. Nurses must ration their attention and use their clinical judgment to prioritize patient care activities across patients when resources are limited. Evidence suggests that results in nurses prioritizing care based on patient needs and may not complete other responsibilities. Consequently, this impacts the decision-making process through which nurses determine which elements of care are completed and which are left undone. In a pandemic situation such as COVID-19, nurses are likely to find themselves in an environment with competing demands, creating goal conflicts due to time and resource constraints that will lead to the need to balance crisis management and professional nursing standards of care. As a result, missed and implicitly rationed care can have a detrimental effect on patient-nurse outcomes. Although an emerging body of evidence exists exploring implicit care rationing and similar concepts, clinical nurse perspectives on implicit rationing of nursing care during the COVID-19 pandemic is absent. Study aims are determine clinical nurse and nurse manager perceptions and experiences about implicit rationing of professional standards of care, and to determine the perceived barriers facilitators of nursing care delivery for COVID-19. This study utilized an exploratory descriptive design. We conducted propulsive sampling of clinical nurse and nurse manager participants on COVID-19 units and the emergency department at the Wilmington and Nemours campuses. Recruitment took place between July 2020 and August 2020. A recruitment email was sent to nurses and nurse managers on COVID-19 designated and the emergency department to ask for voluntary participation. Respondents were screened to ensure they met eligibility requirements. And there was a $35 incentive plus a meal if the focus group was in person. There were a total of 4 60-minute focus groups inclusive of 3 to 4 nurses in 3 groups and 5 nurse managers in 1 group, and 2 separate one-to-one virtual interview sections. Study investigators and nurse participants wore masks during the in-person focus groups and adhered to state and federal social distancing guidelines outlined for institutional policy. Our framework is derived from grounded theory. A thematic analysis was performed by a single investigator doing an iterative memoing process in vivo 12 until a coding scheme emerged based on the themes discovered. A second investigator performed an inter-rater reliability check by reviewing a random 10% sample of the data. Preliminary findings will also be presented to a group of nurses for additional review and validation of themes. The preliminary analysis, the qualitative data revealed 4 categories and 15 themes. Categories are care changes experience, barriers experience, facilitators experience, type of implicit ration care, and missed care. Under care changes, nurses reported utilizing clustered care, where care delivery and orders were grouped that minimize the number of patient interactions and PPE. These were sometimes led by the organization and sometimes led by the nurses themselves. Patient prioritization, and patients were seen in order from the least amount of time required for care to the most amount of time required for care. Nurses were also purposely limiting time in COVID-positive rooms and not going into the room just for a single task. They leave the IV pump, for example, they leave the IV pump beeping and wait to go into the room when more tasks are required. Barriers included deviation from the standard workflow. For example, filling in gaps left by housekeeping, phlebotomy, wound care, IV care, and there was also multidisciplinary care avoidance, where care team members spent less time in the room and nurses felt that they had to pick up the pieces themselves. Daily communication initially was only through email, and many nurses missed the email, not have time to check them. Staffing was also an issue, and there were reports of being understaffed on units for a variety of reasons. Finally, barriers with PPE. With a combination of efforts to conserve PPE and a perception of inconsistent training methods reported as well. Facilitators' experience included nurses and multidisciplinary teamwork. Use of non-clinical staff as runners was also reported to see. Runners would gather supplies for nurses, providing extensive care in patient rooms at a given time. Nurses in the rooms would write on the windows, and the runners would bring what was needed. Finally, leveraging the use of technology. iPads and personal phones were utilized for patient and family communication. Also, HR adjustments saved time utilizing chart by exception. Implicitly rationed and missed nursing care included medications. Delivery would be delayed for almost 2 hours in some situations due to time constraints. Patient interactions and personal communication with patients suffered the most and led to reduced psychological support from the nurse. Skin was also a reported missed nursing care. Patients returned less frequently, every 3 to 4 hours instead of 2. Skin assessments were not as thorough. And non-bedside assessments, nursing bedside assessments would be skipped in favor of care team personal safety. Some team members would not lay hands on patients or go in. Sorry, I realized during the middle of my presentation, I pulled up the old slide deck. So I'll go through this. Some other findings that we found, there's delays in imaging and procedures, nurse interruptions due to communication needs with family, and compromised communications. Reports of nurses not feeling safe and need for increased emotional support. So some insights in the literature. Implicit rationing and missed nursing care are both already universal phenomena experienced in healthcare on a global level. This is not unique to one institution. Potentially dangerous and has been shown to impact patient outcomes of care. COVID-19 likely increased the prevalence and the type, but to what extent? The most consistent predictors of missed nursing care are the work environment, staffing levels, and nursing teamwork. Strategies for improvement include evaluation of the organizational staffing plans, including search plans, and the creation of reliable supply chain for medication, clinical supplies, and equipment that may contribute to nurses' capacity to complete all required care. Improving the nurse work environment within the context of organizational culture will allow teams to become adaptable and potentially mitigate missed care and implicitly rationed care. And finally, considering the role of the nurse leader, considering the role of the nurse leader leadership style. Emotional intelligence has been shown to have a significant association with perceptions of less implicitly rationed. Implications of these findings: understanding the barriers and facilitators will aid in the development of pandemic-specific interventions for caregivers. Staff and leaders could potentially be positioned to live in an agile state of readiness for care. And workflows could potentially streamline for pandemic. With empowerment to streamline nursing care, the reduction of moral distress as it relates to missed care can be potentially, and also inclusion of the voice of the nurse, promote empowerment to drive positive change is always in certain situations. Thank you.
Thank you, Monica. That was great.
Thank you.
I hear some people may be having some audio problems, a little sketchy. I'm not quite sure if this is, based on people's own computers or not, but put in the chat box if you can't hear. So our next presentation is titled Exploration of a New Virtual Nursing Care Delivery Method During COVID-19. And it's going to be presented by Dr. Julie McCulloh Nair, Associate Professor of Nursing at Westchester University, and Dr. Susan Burkhoff, Nurse Scientist at Christiana Care and Affiliated Assistant Professor at the University of Delaware School of Nursing. Take it away.
Thank you. Thank you for that introduction. And, let's hear, click. Come on. Okay, good. computer's slow. Come on, start. Here we go. Can everyone see that? Thumbs up, yeah? All right, yeah, I see a big thumbs up, thank you. And let me see if I can minimize this. Got it, okay. So thank you so much for that introduction. And also, part of our team with both me and Julie is Alicia Salvatore, who's a senior researcher and the Value Institute at Christiana Care, and also our home health nursing and leadership team. So they were a very important part too of this study. And it won't move. Oh my goodness. There we go, yay. Well, I don't have to go over this one because we all know why we're here, and we just have no conflicts of interest to share. All right, so a little bit of background and talk a little bit about the virtual nurse visit. So as you can imagine, back in March when everything was shutting down, people were not coming out of their homes or not receiving care, there were, missed home care visits. And during this time, home health leadership was like, we got to do something. Like we have this at-risk heart failure population. They're ones that typically are like a revolving door in the healthcare system where they, they have flare-ups, they decompensate, they need to go in, get a tune-up, and they come back out and they kind of, follow this circle. And so, the home health leadership team was like, we need to address this missed care. We don't want to have any gaps in care. And so they were very proactive in taking a look at this virtual nurse visit program. And during this time, it was like very serendipitous that Julie and I were talking to one of the SVPs there, and we're putting together a research study while they were implementing this. So everything was moving fast. But this virtual nurse visit is definitely an innovative way for home health care nurses to really connect with those heart failure patients and, to avoid having missed care. But, with technology, and of course, as you can imagine, home health or the heart failure patients, they're elderly, they're not digital natives. So if you give them the device, maybe they know how to use it, maybe they don't. And so we just can't throw hardware and software at them and be like, you're going to use this, right? You know what you're doing. So, to address this and really, we're trying something new, we're trying something innovative, and we really want to know if we're going to give you this hardware, software, can you use it? What are the facilitators and barriers to using it? Would you adopt it? Would you, adopt it into your typical care? And so this is what we were looking at because, home health was really trying to, be innovative and look at a new care delivery model. So the virtual nurse visit, so it is a telehealth visit, and it's a synchronous video meeting with the telehealth nurse, and the telehealth nurses are home health nurses, and they were using Zoom video conferencing. And during this time, they would go over, how they're feeling, their current state of health, if they're having symptoms, how to manage those symptoms, if they needed to give some education, boosters, go over their medication, make sure they're complying with their medication. And this all happened within like a 20 to 30-minute visit. So then our specific aims for the study, so, we wanted to really take a look at, since we are giving, new technology and trying something new, we really wanted to know about this particular population's, their experiences using it, if they could use the hardware and software, and what are those facilitators and barriers to adopting this? And also we need to know about their level of satisfaction, because again, we're trying something new, and if people think this is terrible, I don't ever want to do this, well, then they're not going to adopt it. And of course, we always want to disseminate our findings, and that's what we're working on right now. We have, we're going to go over our high-level research results, and we're going to be working on disseminating those out. So our methods, so we had a mixed method convergent parallel design. So we gave equal priority to qualitative and quantitative data collected. Our theoretical framework that helped guide the study was the fusion of innovation. And that really looks at different elements of adoption. And then our outcome variables, we're looking at experience, we were looking at usability, we were looking at satisfaction. And our measurements, we were looking at sociodemographic data, we were using the system usability scale. And then we also had semi-structured interview questions. And I take it back. So the SUS and the semi-structured interview questions were happening at that third visit. So for our sample and setting, so our population, as I mentioned, it's heart failure patients, and they were at risk of, being rehospitalized, and they had to be receiving the virtual nurse visit because, there's patients that were receiving the virtual nurse visit, but, were not participating in our study. but they need to sign on for that first before we could pitch the study to them. And then the setting, they were either in their home or they were in an assisted living residence, and they were receiving care through home health. So you can see I have listed the inclusion-exclusion criteria, but I just want to draw your attention to inclusion. Down at the bottom, we have receiving the third virtual nurse visit. And, this was like instrumental working with the home health care team. When we were planning this and like, when should we collect the data? When's a good time? They were all in agreement that third visit was a good time because, the first one, they have to put in all those numbers for a Zoom call and, just to learn how to hold it. Like we were told that, like elderly patients want to keep their finger on something and don't really like to tap. So figured talking to them, and they really felt like, the first, second one, they're trying to get over the hump, they're trying to learn. It's a good time for the third visit. And the third visit too, because the timing could be different. Like some people may have it every few days and they have a third visit, and in other ones, it may be stretched over like 2 weeks. So we thought that would be a nice way to maintain consistency around our collected data. And of course, exclusion criteria, patients were hard of hearing because this is the elderly population. They had a hard time seeing, if they were disoriented, and then if they were only scheduled for one home health visit, because there are some people who are discharged from the hospital and they just have one visit and that's it. So they needed to make it to the third visit so we could collect data. So just some high level sociodemographic results. So we had 34 patients who participated in our study, and the mean age was 75, and the age range, as you can see, it's older adult to elderly. I mean, we have 59 to 98. So we had, I'm like, wow, we got a 98-year-old. That's awesome. And then for gender, we almost had an even breakdown between male and female participants. So for race, you can see we definitely had a lack of diversity. It was predominantly white patients who enrolled into our study. We did have some Black or African American patients, but no other races were represented. And when we had a meeting with home health and just asking, like, is this representative of, the home health, like the total home health heart failure patients that you serve, they were able to do a high level view. We're going to have to, at a later time, really dig down and take a look at, their typical population demographics. But this does kind of mirror, I mean, not exactly, but it does mirror to a point the population that they serve. And then for living arrangements, so, as you can imagine, when, elderly population, so a lot of them did live with another person. I mean, some did live alone, but most lived with another person. And we didn't have anyone who lived in an assisted living facility enroll into our study. And then so for the quantitative results, so the system usability scale, so this scale is widely used. It is highly reliable and a validated tool. And essentially it's taking a look at, how easy or hard it is to use a new innovation. The questions are kind of broad, so it doesn't necessarily have to be technology, but something new. And the questions are like positive and negative, so they're bare to code on the back end. But looking at just the whole picture of the how usable was, Zoom, the virtual nurse visit, and we sort of have like a bell shape going on here. But based on the scoring for the SUS, 68 is the cutoff. So if you're 68 and above, your system's usable. If you're 68 or below, 67 and below, there's more work to be done. And you can see we almost have an even split. I think it's like 18 usable, 16, more work needs to be done. And so when I looked at that, I was like, kind of thought that it, because looking at the qualitative, it kind of thought this would have been skewed a little bit more. So I was a little surprised. And then when you look at, this is the actual questions in the breakdown. So you can see how they go positive, negative, positive, negative. You can actually see what's asking. And so for questions 1, 2, 4, 5, 6, 7, 8, 9, those are very specific to usability. And you can see for the most part, the positive ones, they agreed, like that they would use this. They found it easy to use, or it was negative, like it was too hard, it was cumbersome, it was complex. They disagreed with it. And it's like, that's interesting, because again, the previous slide showed it was almost an even split. But I think where it's coming down to, if you look at question 4, I don't know if you see my mouse. So if you look at question 4 and you look at question 10, See how they're an even split between, or almost an even split between disagree and agree. You see it here again. Those are learnability questions. And so it seems like the virtual nurse visit is usable. However, there seems to be this learning curve behind it. And so it's curious because we picked the third, but it's curious how things would possibly change depending on like when we were collecting data. But there's definitely something to be said here that it does overall seem to be usable, but there's something about the learning curve. And we don't know what that is yet, but there's something there. And so I just feel like we're on to something here. Oh, and then I'm going to turn it over to Julie, so she's going to take over the qualitative findings.
All right. Hi, everybody. Oh, a little bit of an echo there. Can you hear me okay? Okay, I think it's clear now. Okay, good. I see thumbs up. Thank you. Okay, so and thank you, Susan. So I want to talk a little bit about the qualitative research findings. As you can see by the 4 themes here, the first is perceived safety, followed by preferences for delivery, then user experience and satisfaction. These are reflective of the questions that we actually asked the patients. So it was no surprise that they spoke mostly to this. In terms, can you go ahead to the next slide, Susan? Sorry. Oh, there we go. Okay, so then in terms of for discussion, so like Susan talked about, you know, a lot of the patients here, you had that 50-50 split. They did have a technology challenge. We expected that. What we're thinking though is that like for the most part, for whatever reason, it was typically the daughter that needed to be present to set this up for our elderly population. Not to say the sons weren't there or even a grandson was there, but for some reason it always had to be a caregiver for the most part that had to set this up, initiate the session. You know, we got a lot of responses that were like, oh yeah, it's great, we can use this as long as someone sets it up. So there is definitely that learning curve that we need to figure out here. Patients also commented a lot on the difficulty with how they had to link to the sessions. So for the home health, what they initially were doing, we're sending a number and then you had to put a password in. Like Susan said, everybody wants to just hit like one button and be done. So when you're asking an elderly patient to be typing in a bunch of numbers, then follow with passwords, that got very difficult. So, and they had been doing other virtual visits with their physicians where it was just one quick click, you know, and boom, they were right into the session. So that's something that home health has already transitioned to that method. So that's something we figured out early on. And then the other problem too was that we found that, so a lot of the patients said they still want that face-to-face with a nurse. That's still that comfort level there, but they kept saying that they really enjoyed the virtual visits and they wanted to make sure this was a supplement moving on into their plan of care for a couple reasons, which we'll get into in the next slide if you want to switch over, Susan. So definitely this patient experience was completely enhanced by using this method. It really relates to the convenience of this virtual visit. A lot of the patients were so happy they did not have to leave their home. They did not have to get dressed. They did not have to get out of bed in some cases. And that was seen as a huge plus for a lot of these patients. So the other thing too is people brought up that they had less interaction sometimes that they had to have with their physicians. It kept them out of that doctor's office because they had a nurse who could go over some of the education with them, talk more about signs and symptoms. So that was another thing that patients had commented on a lot. It was like, this was great because it saved me time from having to go to that visit. I didn't have to spend money on gas. I didn't have to arrange any kind of transportation. Nobody had to take off work to get me to that visit. So that again was a really big plus for the patients. And the other thing that Susan also mentioned was that for some reason, it was something else that we really need to look into. Our patients were all at home, which was surprising because we really expected to see some that were in assisted care. So we're not sure if patients were just brought home because of COVID concerns related to sending a loved one to assisted living or long-term care. But that was something else we do want to take a look at. And then also family members were happy having that loved one at home with them. They didn't have to miss work. They could help them set up this session. Some of them really appreciated having the ability to sit, you know, at that session and really listen into what the nurse was telling the patient. So it was a benefit to family members too. And then also what was interesting that we found was that patients actually perceived an increase in the length of their visit, although there's no difference between virtual versus face-to-face. Then we think this goes back to the consistency, like what Susan said. This was conducted on the third visit. The same exact nurse was seeing the patient every single time. So there was this great rapport that was already built. And then they could just dig right in. They didn't have to keep going back and looking at the records and getting to know the patient again. They could just jump right in and say, okay, let's leave, where were we on Tuesday? Let's build on this. So they had more time to spend in terms of educating the patients, really talking about signs and symptoms, plan of care with them. That's something that they don't always have time to do during that face-to-face visit. So there was a real big benefit to having the virtual, which goes back to why they're saying we really would like to see this as a supplement to their care moving forward. And then, Susan, do you want to go ahead on to the next slide? Then for our limitations, obviously this is a convenient sample. So of course, there's probably some selection bias here. Some patients just wanted to participate. And then also we did have a lot of patients that were of advanced age. They had a lot of different specific needs, right? In terms of virtual limitations. We tried to be very careful about that in terms of exclusion, but even with that, I mean, some patients we found did not have the dexterity to particularly hold a certain type of device. One thing we found is a lot of them were using phones, which, as you can imagine, with an elderly person trying to see the smaller screen or even have the dexterity of the smaller numbers. So that's something else we need to look at in the future too, to see what kind of equipment is really best suited for this population. And then the other thing was that data collection occurred during the summer. So we're not quite sure if some of the COVID fear may have dissipated at that point or not. And then Susan, if you want to go to the next slide. And then for this one, we just wanted to show you, it absolutely took a village to complete this study. As you can see how many people were involved with this. It went far beyond just Susan and I being nurse scientists at Christiana, and then having Alicia as our senior scientist. This really, without home health, we could not have pulled this off. And then if you want to go to the next slide. And then I believe questions are just going to be held until the end. So you have our information if you need to contact us.
Thank you, Susan and Julie. That was great. I want to move on to our next presentation. This next presentation is titled, How Does the Pandemic Affect Families? The COVID-19 Exposure and Family Impact Scales. And this will be presented by Dr. Ann Kazak, who's the director of the Nemours Center for Healthcare Delivery Science, as well as professor in the Department of Pediatrics at the Sidney Kimmel Medical College at Thomas Jefferson. So Ann.
Great. Thank you so much. If my sound is not coming across, somebody let me know, okay? Want to make sure you can hear me. To figure out how to advance my slides. Okay. So I'm very grateful for the support of the CTR grant for this work. What we did was very rapidly develop a measure to look at the families' exposure and the impact of COVID-19 on families. This work was also supported by a grant that we have from SAMHSA, which is part of the National Child Traumatic Stress Network. And I wanted to start with my acknowledgments. This was an amazing process, really. We had many people at Nemours pull together to develop this scale very quickly. And we also collaborated with associates at Children's Hospital of Philadelphia and Cincinnati, and included 2 parent advocates as we developed the scale. So here we go. So the goals then are to talk about how we developed the scale. I like acronyms, so this is the COVID-19 Exposure and Family Impact Scales, or as we affectionately call it, the CEFIS. I'm going to present some psychometric data that we collected very quickly from a database of users in the United States, and talk a little bit about what we see coming up next. So, it goes without saying, the word unprecedented has been used many, many times in 2020, and certainly the global pandemic has had a huge impact on children and families. It's starting to change a little bit, but what we saw in the first 6 months or so of the pandemic was really a lot of opinion pieces, a lot of very eloquent editorials and similar, but not too much rigorous data in terms of the actual impact of the pandemic and the restrictions on children and families. And one of the first things that occurred to me when this happened was, this is going to have, COVID is going to have a big impact on research that's already ongoing. This is a major, if you will, contaminant in research procedures and with outcomes, given particularly those of us that study psychosocial behavioral outcomes. We also felt that a medical traumatic stress model was very relevant here, and I don't have time to go into this, but basically, it's not too difficult, I think, to appreciate that many aspects of the pandemic are potentially traumatic to kids and families, and so therefore it fit within other, it was consistent with other illnesses and injuries that we've looked at from a traumatic stress model. So here's what we did. We wrote the scale very quickly over 22 days. It was a great process, lots of back and forth very quickly. We, in organizing the scale, we looked first at items that relate to exposure. And we came up with 25 items. They were yes, no responses. And they range across school, housing, employment, missing events, etc. And we also had 5 items that are about direct experiences with COVID-19. Then in the second part, we asked about the impact using Likert type scales there, from made it a lot worse to made it a lot better to made it a lot worse. And we wanted to consider the fact that there were some silver linings here, or there might be some positive things that people would want to discuss. And the third question was an open-ended response, which I'm not going to talk about today, but I tell you, people really wrote a lot of very interesting things, much more rich information than I would have predicted. So we announced, CEFIS was made, we announced it on listservs in April. It is available in English and Spanish. We also registered it at the NIH, the Disaster Management Research Center. We don't charge to use it, but we do ask people who agree to use it to share de-identified data with us via REDCap. And that's what I'm going to highlight a little bit here in terms of talking about some of the analyses that we did using exploratory factor analyses to identify the underlying structure and to look at the internal consistency of the scales. So first of all, at this point, who's using the CEFIS? It was very popular, many responses as soon as we announced it. We have 129 users who are registered with us, and at this point, we have data on 3,200 forms. As you can see, it is global. We have people using it all around the world, and a number of translations that are underway as well. So the data that I'm presenting today is actually part of a manuscript that was submitted, so it doesn't include, at this point, the full data set. We probably will rerun some of the analyses when we hopefully get an encouraging editorial decision. But this was with 1,800 caregivers from 15 academic medical centers and tertiary care centers in 12 states. We had about 78% female or mothers and 22% males. And as you can see there, we have a variety of different patient groups in the sample. So here's what the factor analyses showed. We found it's actually very positive news here. The exposure and the impact scales behaved very nicely, behaved very well. The exposure alpha for internal consistency was 0.8 and for impact 0.92. And they fell out very nicely into 6 factors for exposure related to COVID-19 experiences, accessing essentials, we call disruption to living conditions. Error there on the slide. There's not sure which scale that's supposed to be. There's one missing here. Disruptions to family caregiving, and activities, and designation as an essential worker. And we want to pull some of those out and look more closely at them. And then in terms of impact, we had personal well-being, family interactions, and distress. This may be a little difficult to see, but I wanted to just show you the results of the exposure items. So overall, the mean is the number of items that were endorsed as yes. And as you can see there, it's 8.7. And it goes from, we have a nice distribution here from our schools, our childcare were closed, 93.8%, down to, on the right side of the slide, the what we call the the direct exposure items. Someone was hospitalized, 8%. Someone in the family was in intensive care, 7%, or someone died at 5.8%. So it's quite striking the exposures across the families. What does the impact look like? So the impact was scored on a different scale, a 1 to 4 scale. And you can see there the red line in the middle shows the halfway point there, 2.5. And the items all are around that level, although the highest score above 3 was for anxiety, followed closely by mood, and all the way down to at the other end, less impact in terms of caring for their child with a medical problem, caring for other children, and how family members get along. So we saw a little bit of a differentiation there in terms of the impact on families. So where do we go from here? We're very excited that the measure has held up in terms of these initial psychometrics. We want to understand more now as the pandemic continues of how it's impacting children and families over time. We're also looking at some of our colleagues, Lee Fan and Paul Enlow, have a two-step grant from the ACCEL and looking more at healthcare engagement and how the impact and exposure to COVID impacts engagement with healthcare and with the healthcare system. We thought that this is not a surprise from everything that we've lived for the past 9 months, but the extent of exposure is very significant. It's broad, particularly parent anxiety and mood is quite marked. We did see indications of adaptive resilience. Some of the items that were endorsed as being somewhat on the more positive side as opposed to the negative. The biggest limitation of this data is that we don't know much about the sample because it was de-identified data sent to us. So there's a lot of interesting questions that we're not able to answer from this particular data set. But we will be able to do more with the two-step grant. And then our future steps include analyzing the data from the Spanish version, which we have less data, but it is slowly coming in. And we also developed an adolescent and young adult version that will be interested in analyzing those data probably right at the start of the new year. So that is the conclusion of my presentation. We would be happy to talk with people about the CEFIS or about using it. And I also put up on this slide some of our other COVID-specific resources that we've developed for patients, families, and healthcare providers.
Great, thank you, Anne. That was wonderful. Okay, so our final presentation is titled Barriers to Utilization and Impact on Patient Experience and Outcome, Telehealth in Pediatric Cardiology During the COVID Pandemic. And this will be presented by Dr. Carissa Baker-Smith, who's the Director of Pediatric Preventive Cardiology at Nemours and Associate Professor at the Sidney Kimmel Medical College. Carissa.
Okay, I'm just trying to load my slides here. Can you see that? Yeah, can you see the slide?
No.
No? Okay, hold on one second. How about now? Yeah? Okay, perfect. Thank you. Sorry about that. Um, well, thank you for the opportunity to present today. As Dr. Packer mentioned, I'll be talking about our ACCEL-funded project, which looks at barriers to utilization and the impact on patient experience and outcomes, the telehealth experience for pediatric cardiology during the COVID-19 pandemic. So just a little bit of background, as everyone knows, COVID-19 kind of came on pretty, I would say changes had to be made pretty abruptly in terms of patient care and patient care delivery. And pediatric cardiology was no exception. On March 16th, we at Nemours started making changes to the way in which we saw patients. And in particular, between March 30th and May 8th, there was really a strong effort and a push for all patients to be seen through telehealth visits. And then after May 8th, that sort of recommendation kind of relaxed a little bit, but the focus of this study will be on that period. And most, like I said, were converted to telehealth, while other visits were either canceled or rescheduled. Okay, so the objectives of this presentation are to describe the findings from our grant, in particular, the impact of social determinants of health and comfort with use of technology on the acceptance of telehealth visits. And that's the technology comfort by the parent, who was the one who was facilitating the visit for the child. And then to assess the impact of that transition to telehealth for pediatric cardiology care delivery on patient outcomes. So, there are a lot of potential drivers regarding the choice to go from telehealth to rescheduled or lack of in-person visit. And so we were interested in what was driving that decision. It could have been a physician choice for sure. We definitely had physicians in our practice that thought telehealth is useless. And I think they said as much. Patient choice, and then diagnosis and disease type. There were also some interest in, one of my particular interests was just what was the social determinants, and were there, things like socioeconomics, language, race, ethnicity, religion, or geography barriers. I included here a picture of an Amish family. We have a fairly significant Amish population as well. So, what were some of the impact of these social determinants on decisions? And then there was the question of whether or not comfort with telecommunication and just technology in general played a role when it came to acceptance of these visits. So our hypotheses were that the socioeconomic factors did in fact negatively impact utilization of telehealth resources, and that the reliance on telehealth may further drive health inequities. So we examined particular sociodemographic factors, including age, race, gender, ethnicity, primary language as recorded in EPIC, reason for visit or referral, the type of visit, whether this was a follow-up or a new visit. And then again, we used 2 surveys to assess both comfort with technology as well as the telehealth experience. And the telehealth technology usability score was used for assessing experience with telehealth during this pandemic. We had a supplemental aim that I won't go into in too much detail for this presentation, but we looked at resource utilization as a result of the telehealth experience as well. So the significance of our grant is that, for children with chronic health conditions in particular, they're the most vulnerable to poor outcomes without appropriate outpatient care or care in general. And so better understanding of the factors contributing to the acceptance or refusal of telehealth and the experience may help to identify potential populations with greater susceptibility to health inequity, as well as to identify factors that might improve the patient care experience. Our study was IRB approved. We did, in fact, focus again on this March 30th to May 8th date, focusing just on the Wilmington Nemours Cardiac Center, as there were different policies and procedures at some of our satellites. We obtained the data for the entire cohort, that was telehealth and canceled visits for that time. as well as, again, we used particular surveys that have been validated. The surveys were distributed through REDCap, although because, again, we were assessing telecommunication and technology comfort, we did, in fact, offer consent forms and survey questions through the mail. Families received a $20 Amazon gift card, as well as and then the collection of the data, and there was a creation of a merged data set. Statistical analyses were performed using SAS, and then there were univariate as well as multivariate analyses performed. And then again, these were the factors. So I'm just going to go into some of our results. So in total, between that, in that 6-week period, there were 849 individual patients who were either seen through telehealth, of 441, which is 52%, or whose visits were actually canceled. And when we looked at the population between those who had telehealth versus canceled, we found that there were some significant differences in terms of which children actually went on to have telehealth versus having the patient visits canceled. So although it wasn't a huge difference, it's only about a portion of a year, younger kids tended to have telehealth visits versus older. You'll notice here there were no gender or language differences, which kind of surprised us because we thought maybe Spanish language, although I will say we did make available a Spanish interpreter for our telehealth visits versus other visits like Haitian Creole, we did not, but even those patients tended to accept telehealth visits. Race was not a factor either if you sort of expanded or condensed the racial group cohorts. Ethnicity was if you removed other. And then religion was interesting with many of our Amish patients choosing not to participate. Poverty status, we used 2018 census data, which is the percentage of families below the poverty level of less than 40% versus greater than or equal to 40%, but found no statistically significant difference, nor did we find a difference with insurance payer type. State was different, so if you lived outside of the Delaware, New Jersey, Maryland, Pennsylvania corridor, which was kind of interesting because you would think those patients would have accepted telehealth because they live so far. And then visit type didn't pan out to be significant either. We did do our best to kind of break down the indications for the visits into the primary diagnoses into about 11 groups. And we did find that there were some statistical differences, which I'll show you in just a second. So this is just a graphic produced just again to kind of show that with the blue being telehealth and the red being canceled, in terms of poverty levels, if you on a linear basis, these are the percentage of the population below that 40%. There really wasn't much of a difference. And then looking by ethnicity, this is looking at a different question. This is just asking the question of among those of different ethnicities, who was poorer, and essentially you see that Black and other had higher percentage poverty versus white, and then Hispanic. And then we looked at insurance type as well. This is getting to the multivariate analysis, and so I ran a logistic regression, just looking at the different variables by univariate analysis that were significant, and found that if you look at diagnosis 0 versus 11, 11 being unknown, and 8, 0 was arrhythmias and palpitations. Those tended to accept telehealth visits. And then for interesting reasons, rheumatic things like acquired heart disease, which included like a history of rheumatic fever, myocarditis, it was interesting that those were the ones that kind of shifted out. Running a ROC curve and best fit model found that model 1 was probably the best fitting, and that included also state as well as religion and diagnosis category as well as age and years. So from our analysis, we found age, religion, ethnicity, state, primary diagnosis were associated by univariate analysis, whereas race, gender, payer type, language is not. So for sake of time, I think I'm running short, but I'll just keep going. So patient outcomes, we wanted to assess what was the impact of transition to telehealth for pediatric care delivery on patient outcomes. We used rescheduled versus scheduled visits, and we really went through and looked at the reasons for the cancellations as well. I won't get into too much detail. If people have questions, we can come back to that. But I wanted to highlight a couple of things, and that is that when we looked at ED visits, there were no different, and admission visits, and there were no deaths. So despite the fact that patients maybe had either telehealth services or even for the rescheduled patients, a delay in care, there were no deaths associated with that decision tree. Now, mind you, we looked at a short period of time. It was 6 weeks, but you're also talking about a pretty high-risk population, kids with some congenital abnormalities as well. I just want to highlight here, we also looked at a comparison. There were 774 observation individual patients in 2019 during a similar period of time. So other things that we looked at, again, getting to the resource utilization piece, but just kind of showing how we were able to do things in 2020 during this period, like EKGs. Obviously, we had a higher frequency of EKGs performed during 2019, but the distribution seems a little bit similar. We still had kids who had 2 or more EKGs, and they were allowed to come in and get their EKG and echo only visits if needed. Similarly, we looked at echocardiogram, Holter, stress tests, and other cardiac catheterization, as well as other forms of imaging. And then looking at the ED visits, we also compared that. The last thing I want to highlight is just response to our surveys. We had, for the telehealth only, we had 105 people that responded, about a quarter, and 113 for the canceled visits. So 218 total surveys were analyzed, and we looked at the differences between those who completed the surveys and those who didn't. There were some differences by race, with white patients being more likely to complete the surveys. But again, we did take a look at that. Just to highlight what came out when we looked at technology comfort and the impact on whether or not someone, what was the impact on whether they accepted telehealth or not. I'm just going to show you the positives. There were about 19 questions or so, and several were positive. And that is, we really found that people had some experience, parents who had some experience with Skype or video conferencing tended to select telehealth. Those who found technology to be useful, those who were not easily frustrated by technology, those who didn't give up if they had a technology-related problem, tended to accept the telehealth. And then the 2 key was looking at the telehealth usability questionnaire, and this was a long questionnaire. There were really 21 questions. But the general sense, the ones that are the lowest or really didn't apply to our group, which is, if they had some system error, were they able to fix the error? Were they able to get help with the error? We really didn't have any systems errors reported. So, and overall, the experience with telehealth was good, with people rating their experience quite high. And just looking at the completers versus non-completers again. I did have one quote from one parent after I had given this presentation of data a while ago, and she said, when I was offered the opportunity to reschedule, they couldn't tell me anything about the appointment. I wasn't sure if that changed since this was around May when it occurred. I couldn't see how an EKG or echo standard for our appointments could be done. And since we had a CAS schedule at another institution relatively near the appointment, we opted to cancel. I think having more education and understanding of what the appointment would entail would have been helpful in making more educated decisions. So there was some, we didn't have a qualitative portion to this study, but I think it's worth noting that there may be other things that we weren't capturing. So in conclusion, with few exceptions, we really didn't find that there were true sociodemographic factors that we would have thought might have predicted the acceptance versus not a telehealth. Outcomes were largely no different. Level of comfort with use of technology varied, and it seems that parents who were more comfortable tended to accept the telehealth. And then overall, the response to telehealth use, as assessed by our usability questionnaire, was favorable. So, thank you. I think I made it.
Great, thank you. So we obviously don't have time for questions, but I'd really like to thank all of the presenters for their research. I'm just amazed at how much was done on all of these projects in just a 3-month period, which is pretty amazing. So kudos to everybody. Also, much gratitude to ACCEL, obviously, in rapidly responding to the pandemic and offering grants of different levels and timeframes. And just as an FYI, the longer rapid COVID 1- and 2-step projects will be presented at the Community Research Exchange in February. So I'd like to thank everybody for attending. If you do have questions for the presenters, please feel free to contact them directly, or you can contact ACCEL and we can get it to you. So thank you all for attending, and we look forward to seeing you all at the other Innovative Discovery Series and also at the Community Research Exchange in February. So thanks.